Hi, everybody. Welcome to the Quench Life podcast. I am Jillian. We thank you for joining us today. I'm super, super excited to be joined by Christina of Uplift Physical Therapy down in Orleans. She is joining us today to talk about pelvic floor health. So, Christina, why don't you introduce yourself and just tell us a little bit about you?
Sure. Thanks so much for having me, Jillian. My name is Christina Lee, and I have been a physical therapist for almost a decade, and I primarily specialize in pelvic floor health. I also do orthopedics, and I work with infants with breastfeeding challenges. So I get to work with a lot of really cool local families. I opened my practice about 2 years ago, Uplift Physical Therapy and Wellness, and we moved into a new space. Now we're in Chatham, actually. And we
In
moved.
Chatham.
Yeah, exactly. We moved in here in April, so it's different, new since we saw each other last. And I um, mostly work with women, but I work with people all across the gender spectrum, and I get to work with really cool things like people who are experiencing problems with urinary health and bowel health and sexual health, and help them work through those things that, might typically be considered embarrassing or taboo, but are totally normal everyday part of my life, and get to help them feel better and function better and do the things they love. So it's a really cool job, and I love what I do.
Yes. It's good to have a job you love. I agree.
Definitely. Yeah.
So today I wanted to chat with you about the pelvic floor just because I think for our moms growing up, pelvic floor was kind of something that we didn't talk about. And so many women that were surrounded around won't jump, have issues with leaking and stuff like that. So just to kick us off, can you just explain what the pelvic floor is and why it's so important functionally for us as women?
Yeah, absolutely. So the pelvic floor muscles are a really important muscle group that most of us know very little about. We kind of take it for granted when it's working, and then when it's not working, we really tend to not know what's going on. It's a sling of muscles that kind of fills the bowl of your pelvis. So our pelvis is a bony structure that makes kind of a ring at the bottom of our spine. If you feel the pointy part on your front of the hips, that's the front of your pelvis. And in that kind of ring of bone, there's no bones underneath that support us from below. And so everything that's holding us up from below is all muscle, and that's your pelvic floor. And the muscles fill that space, and they wrap around your urethra where we urinate. For women, they wrap around the vagina. For men, they wrap into the base of the penis, and then they wrap around the anus. And so when they contract, they close off those openings and lift up toward the head. So they keep us continent. They hold in urine when we don't want to urinate. They hold in stool when we don't want to have a bowel movement. And then when we want to go to the bathroom, they're supposed to let go, open, allow us to completely empty urine or stool. They also play a big role in our core. So, our pelvic floor, our abdominals, our back, and our diaphragm muscle all work together to kind of stabilize us in all directions in our core. And so, they're a really important part of that movement system and structure. And they also play a really important role in sexual function. So, the muscles are supposed to, if we're having penetrative intercourse, they're supposed to relax and open and allow that. And then with throughout the course of sexual activity, there's a lot of contraction and activity that happens with the pelvic floor muscles. So when they're working well, all of those functions tend to work well. If they're not working well, we can have problems in any of those areas, whether that's poor core control, issues with incontinence, issues with constipation, issues with pain with sexual activity. So there are a lot of different areas in our life that can become involved when the pelvic floor isn't functioning optimally.
Yes, I didn't realize how in depth and coveraging the pelvic floor covered for not only women, but for men. So that was super informative.
Yeah, definitely. I think, most of us don't realize that every single person, unless for some reason they don't have a pelvis at all, has a pelvic floor.
Yeah, yeah. No, that was really informative. So, what are some common misconceptions that we see specific to women with the pelvic floor?
Yeah, great question. There are lots of them out there. I would say the biggest one is just the misconception that it isn't really something that we can control or, that we even really know that it exists. But a really big one is that there's an assumption that, especially after childbirth for women who have children, there's an assumption that you're going to have pelvic floor problems. Those muscles will be damaged by childbirth, and there isn't really anything you can do about it. So I couldn't even begin to count the number of times I've had women come into my office and I ask them if they have incontinence. And their response is no, well, only the normal kind. And there really isn't any normal kind. There's a common kind. It's something that many women experience, but it's never normal to be leaking. It's never normal to feel like your insides are falling out. Again, very common, but there's something we can do about it. So, generally speaking, I think there's just a misconception that it becomes problematic over time and it stays that way.
Right, and that there's no cure for it or a way to fix it.
Exactly.
So beyond leakage, is there other less talked about signs of or symptoms that come along with pelvic floor dysfunction?
Yeah, definitely. Leakage is certainly the most common one, but I would say Um, the second most common one would be constipation. An estimated 50% of the American population will have constipation at some point in their life, and that can be caused by a few different things. It can be caused by a motility problem, so your intestines are not moving digested material fast enough through your digestive tract. It can sometimes be caused by dietary issues like you're not eating enough fiber, drinking enough water. But the one that no one ever thinks about and I don't think we know the true incidence of is the pelvic floor piece. So, do our muscles lose the flexibility to open and lengthen and relax and allow bowel movements to come out? So I think a lot of people out there are struggling with that. They're like, gosh, I couldn't eat any more fiber if I tried. I'm drinking all the water they tell me to drink. I'm taking the Miralax, and it's not getting better. And that's because they're not really getting at the root of the problem.
Yeah, that's another check box. I didn't know that either. So here we are on our learning journey together.
Definitely. And, constipation in women is a big cause of back pain. So we'll see a lot of women with back pain and they've done all the regular PT and there isn't really an MRI finding or something that explains why they're having back pain. It's because there's so much pressure in their system because they're all backed up that it can put pressure back onto the back. So we don't just see it present with bowel symptoms, but present in other ways as well.
Yeah, that is super interesting. I had no idea.
Yeah. Most of us don't.
Yeah, no, that's true. And I feel like, when you go to a general doctor, we don't have this information to ask more questions. So hopefully somebody's listening that's like, "Oh, geez."
Definitely.
So how prevalent are pelvic floor issues? Why do you think so many people just consider the leakage and everything that we experience, especially, maybe after childbirth or whatever it might be, that it's just normal?
Yeah. Um, it's a great question. So prevalence, I think, is generally speaking underreported. So we can only track prevalence when we know about people's symptoms. So the estimated prevalence of pelvic floor disorders in women across the lifespan is 25%. So at any given time, 25% of women are having a pelvic floor dysfunction, but it goes up with age. So by the time you get over 80, the prevalence is over 60%, and it kind of goes up gradually between the ages of 20 and 80. I think it's probably higher. I think, for example, things like constipation, people don't know how often they're supposed to go, so they're not reporting they're constipated even if they are, or pain with sex. I've had women come into my clinic and I say, "Do you have pain with sex?" And they say, "Well, just the regular kind of pain with sex." And I'm like, "Hey, there isn't really a regular kind of pain with sex." And so because of all of the misconceptions, I think there's an underreporting. So I personally think that the numbers are quite a bit higher. And in terms of like why people think that these dysfunctions are normal or they just have to live with it, I think there's a lot to unpack there that I could probably talk for like a full hour about. I think there's cultural pieces where because all of these topics are considered taboo, people aren't talking about it. They're not asking questions about it. They just sort of hear, little bits and pieces from people around them that, like, oh, they're leaking too. Or I know my mom used to pee every time she sneezed. And so they just assume it's normal. I think the other piece is that even if they do ask for help, like if they go to a doctor, a gynecologist, or a primary care physician and say they're having a problem, a lot of these topics are not covered extensively in medical school, and even their doctors aren't totally sure what's normal or not. So I've even had women come in and say, well, my gynecologist told me that, of course, I'm going to leak after I had a baby. That's just what happens. And it's not because they're jerks, it's because they
Yeah.
have not been provided the correct information either in their training. So I think there's a lot of pieces to that puzzle.
Yeah, that's super, super, super interesting.
Yeah.
So, what is when people talk about having like a prolapse or a leaking issue, what does that mean that as a woman we're typically feeling? Could you kind of like walk us through what that is for those of us that might be kind of like, am I leaking? Just walk us through
Yeah,
that.
definitely. So prolapse and leaking can come with a lot of crossover, but they also have some differences. So leaking is any involuntary loss of urine. So leaking or losing urine at any moment that you are not intending to. So there are two different types of incontinence or leaking. You can have stress incontinence, which is leaking with any increase in pressure onto your pelvic floor. So that would be things like coughing, sneezing, laughing, jumping, exercising. So anything that kind of exerts force onto the pelvis, and the pelvic floor is not able to meet that change in force. And so it can be anything from a drop to a loss of several tablespoons or even the full bladder. And then there's urge incontinence, which is leaking urine when you have strong urge. So if you, for example, feel like you have to pee, the urge gets really strong, you're on your way to the bathroom, and you either have some loss of drops or a large amount on your way to the bathroom. That's urge incontinence. A sort of subset of that is key and door syndrome, which is you pull into the driveway, you start to put your keys into the door, and you start leaking then. That's a really common one, so much so that it has its own name. And that has a lot to do with kind of a disconnect between the brain and the bladder and the reflexes that trigger us when we have urges. And so, and both of those are treatable. And so whatever the context is, the main symptom of leakage is an involuntary loss of urine. Sometimes people will just say their underwear are wet and they never actually felt the urine coming out. That's still incontinence. And then prolapse is more of an anatomical change that can sometimes have the symptom of incontinence. But prolapse is when our pelvic organs, which is our bladder, our uterus, if we still have one, and our rectum, they all kind of line up together around the vaginal canal or the vagina. And over time or with childbirth or hormonal changes, those organs can start to descend downward toward the opening of the vagina. And so if the bladder descends, for example, it'll kind of drag the vaginal wall with it and it'll come toward the opening of the vagina. So if you were to look inside the vagina, you would see what looks like kind of a red bulge. What you're actually looking at is the vaginal wall, but it's the bladder pushing on it that creates that bulge. The uterus can come straight down on top and do the same thing, or the rectum can come kind of forward from behind and do the same thing. And so it changes the relationship between those organs and the muscles that support them. And typically the symptoms that'll come along with that is people will say they feel pressure in their pelvis or in their vagina. They'll sometimes say they feel like there's a golf ball in there, or they feel like they're sitting on something, but they're not. They feel like they'll feel like things are falling out. And so those can be really kind of concerning and alarming symptoms, especially if you're not aware of the fact that those are things that could come up, particularly if it's a bladder prolapse that can oftentimes come along with either stress and or urge incontinence. So there can be crossover there. But either way, they're symptoms that, nobody wants. They don't feel good and they can be alarming. Like I said, especially if no one ever tells you that that can happen. So there's certainly things that a lot of women are dealing with. And if someone out there is listening and saying, that is a terrifying feeling, you're totally valid in feeling that way because it certainly can be.
Right. So what you're communicating to us today is any leakage is it normal. We shouldn't be just dealing with it or fighting through it. Don't tell our moms, but unfortunately, our moms were wrong with this,
Yes.
that it was well,
Yeah, exactly. They would have probably been thrilled to have the opportunity to learn that it isn't and that there's something that can be done. But, in those days, it just wasn't something that you talked about. So
so
something,
earlier, sorry for interrupting, but
no
earlier
problem.
you had mentioned that as women age, it seems to be a more rapid increase in this issue. So do you know why that is? I'm just being nosy of why as
Sure.
we're getting older that gets to be greater for us.
Yeah, definitely. So, in some ways, the research on this is still developing because it's women's health and it just hasn't been a priority for a very long time. But what we do know is that as we age, our hormones change. So, with menopause, and even into our 30s and 40s, kind of approaching menopause and that perimenopause phase, estrogen levels in our system drop, and the pelvic floor muscles, all of our muscles, but especially the pelvic floor muscles, have receptors in them for estrogen. So estrogen binds onto the tissues. And without kind of getting into the cellular biology too deeply, that triggers some other responses in the cells, opens up some channels that allow, for example, increased blood flow, the movement of nutrients across the cells. And so estrogen is really key in being able to build and maintain muscle mass. And so that's a big part of why as we age, and I'm sure you see this a lot in the gym, Jillian, as we age, we have less muscle mass, and a part of that is estrogen. And so when that happens to the pelvic floor, is if we used to have, a certain amount of muscle there, as we lose some of that muscle with age, we suddenly anatomically don't have as much tissue there to support our organs, and we can have symptoms that maybe initially come from an injury that happened after childbirth, but your body was kind of able to compensate because you're young and you've got lots of estrogen, and we lose the ability to compensate.
That's super interesting.
Yeah. And so, like, that's too why we talk a lot about like doing more strength training as you get older, because your body's not naturally going to hold on to that muscle mass in the same way that it did when you're younger because of the hormonal changes.
Right. So the strength training helps us literally from head to toe.
Exactly. So, there might be strength training people are doing with you, and then strength training to
Right.
their pelvic floor they're doing with me. And it's all the same, idea. It's just a different part of the body.
Sure, sure. So what can you walk me through if somebody wanted to go through some pelvic floor type of therapy? What does that look like? What is the goal? Like if I work with you, am I able to completely get rid of my leaking? Is that something that the physical therapy helps with, or what does that look and feel like?
Yeah, great question. So each person it's totally an individualized approach. And so what the expected outcomes are going to vary a lot person to person. I would say with the majority of people I work with, my expected outcome is that they will eliminate their leakage or whatever symptom they're coming in with. But for example, if they have like a really significant prolapse, their anatomy has changed quite a bit. We might not ever expect it to be 100% better, but we certainly expect it to improve quite a bit. And so the way that I make that determination, what are the expected outcomes and what do we need to do to get there, is to start with an evaluation. And so the evaluation in some ways is like what people may have experienced in physical therapy for other parts of the body, where I like to start looking at movements, looking at their walking, looking at squatting, looking at different movements that kind of clue me into how is your pelvis moving, how about your back and your core, because it's also interconnected. And then I also do a pelvic floor muscle exam. And so for that, I actually have my model here so that I can show you what that is. And I will explain it all as well for those who are not, getting a visual. But so basically, it's like a gynecological exam, except no stirrup and no speculum. So you undress from the waist down, and nothing is done that you don't consent to. So if people come in and they say, I am not having an internal exam, I will absolutely still treat you. It just means like I might be making some guesses about what's going on in the muscles, and we might have to do a little more trial and error than we would if we did more of a thorough exam. And so for as long as you're comfortable with doing an internal exam, we actually start externally. So there's a layer of muscle on the outside of the body underneath the labia. And those muscles connect into the perineum, which is if you've ever given birth and had stitches or an episiotomy, that's where that occurs. And so I like to check that tissue, see if there's any scar tissue, anything that might be kind of limiting the mobility of the pelvic floor. I can look at your tissues and get a really good sense of what your estrogen levels are like. So the color of our vaginal tissues actually changes based on how much estrogen we have. So that kind of help. I look at that to get some information. And then I do an internal exam. So inside the pelvis, where I just insert one single glove finger. So I'm not, again, not using a speculum. It tends to be way less uncomfortable than a GYN exam. Not that you shouldn't get those are very important. But, I do like to tell people that you don't have to have the same expectation. And so then I can use that one single glove finger and feel all these different muscles internally. And I'm feeling for tension. Do I feel like there's a lot of resistance as I push into that muscle? I'm looking for you to tell me if you have any pain as I touch those muscles. And then I ask you to do a Kegel. So, can you pull those muscles, squeeze and pull those muscles in and up? I can grade your strength on a 1 to 5 scale based on how much you're able to squeeze in. And then I do a prolapse assessment. So, I look in the opening of the vagina and I look to see, do I kind of see like an empty canal or do I see an organ, either a bladder, rectum, or uterus coming down into it that we wouldn't otherwise expect to see there? So, it's nobody's favorite thing, like, nobody's like, "Yeah, let's do a pelvic floor exam," but you get such good information that really helps guide the plan. So we might find weakness, we might find tension and tightness, we might find pain, we might find hormonal changes, and we use all of that information together to make a plan for you and also determine, is this something that we think can resolve, or is this something that maybe you're looking for improvement but not complete resolution?
Okay. And is there like you can help anybody at any time, or if somebody feels like they're too far gone?
Yeah. It's a great question. I have worked with people, young women as young as like 12 with pelvic floor problems or girls up to people in their 90s who are relatively bedbound. And of course, my expectations for those two patients will be different and, how much I expect them to improve and what we're going to do to get there. But you're never too far gone. You can always, at the very least, have an evaluation. But I can't think of anyone I've ever evaluated that I have said, "Nope, there's, like, no chance for you to have any improvement."
Yeah, that's good though. I think that that's fantastic. Now, you mentioned Kegels, so what, can you take us down that path a little bit? Are Kegels a positive that we should be doing? Are they helping us? Are they harming us?
Yeah, it is
What is
such a good question, and it's actually a topic of hot debate right now in the pelvic floor world. So, um, I think no matter how I answer that question, there will be pelvic PTs who will think that I'm wrong because it is still an evolving area of the literature. Basically, a Kegel is a contraction of the pelvic floor muscles against gravity. And so the pelvic floor is in that bowl shape. And when you do a Kegel correctly, the muscles should squeeze and lift. That's the movement that those muscles do. And historically, like up until the last 10 to 20 years, pelvic PTs and OTs working in this area would pretty much just give Kegels to everybody. And a lot of people did get better because that's what they needed, but a lot of people didn't. And so we have to think of it a little bit more like what deficits do you have specifically and what do you need to address? So somebody who really has a lot of weakness, Kegels can be helpful. They're not the only thing I would ever give someone, but they can definitely be helpful. Someone who has a lot of tightness and tension and their problem is more that they can't let go of that in order to like have a bowel movement or they're having pain with sex. A Kegel is not going to be the most helpful thing and it could potentially be harmful. So I think the reason why Kegels are controversial is partly because people are blanket statement of, prescribing them to everybody, and that's not appropriate. But I think for the right people and in the right context, they can absolutely be helpful. They have done studies where they've put sensors into people's vaginas and had them do a Kegel and look at the quality of the contraction. with someone just telling them, do a Kegel. And depending on the study, up to 80% of people are doing them incorrectly when they're just told to do a Kegel. And so that's my other issue with Kegels is that when we just tell people, do your Kegels, like, I'm sure there are going to be listeners who have talked to a gynecologist who has said that exact word to them or phrase, do your Kegels. For the most part, they're not doing them correctly. And so it's a waste of their time and potentially making things worse. And so I think if you are going to do Kegels, you should be properly taught how to do them and have that evaluated and monitored, particularly if you're having symptoms.
Sure. That's super good super good information. I'm so glad that we're having this conversation just because it's, I think it's just mind-blowing just how much this is not discussed, and it's such a massively important part of women's health and, us being well as we age. So if I ignore my symptoms, what does that look like? So if I'm in my, early 40s right now and I sneeze and I'm starting to have a little leakage and I'm like, oh, whatever, it's normal because I had a child and I, ignore that. Can you kind of give us a little synopsis of what that is going to potentially mean for me, down the road and why I should address it now versus ignoring it?
Yeah, yeah, that's such a good question because I think oftentimes it's not until an issue is severe that we decide we're going to address it. But I think there are a few reasons why it would be really helpful to address it sooner rather than later. The first is of which is in general, no matter what issue you're talking about, with trying to change the body or the musculoskeletal system, the longer you've had an issue, typically the longer it takes it to resolve, and that's because your body has really set into certain patterns of movement, of utilizing your muscles in certain ways, and it can take a lot longer to change that when you've been doing it for a long time. Specifically for the pelvic floor and for women, we talked about those hormonal changes and how the lower your estrogen levels go, the more you can lose pelvic floor muscle mass. And so if you're trying to address incontinence when you're 80, it's not that you can't make changes, but we have to think a lot differently about it. Like, what are you eating? What kind of protein are you getting in so you can maximize building? How many months and months is this going to take to build the muscles versus when you're still in your early 40s, you still have quite a bit of circulating estrogen. And so you have a little more muscle bulk to work with. And so things are going to get better quicker. So just the timeline is different, but then also the symptoms might become more severe. So if you're having just a little bit of leakage now at 42 with sneezing, you could probably expect if you do nothing that by 72 you're having like a moderate amount of incontinence with coughing, sneezing, laughing, jumping. Maybe you've had to stop doing certain workouts because you're leaking with them. And so when you start at that point, just have a further distance to go to improve. And so you're just setting yourself up for an easier second half of your life if you kind of address it in the first half.
Yeah. That makes total sense. So, what should one do? So, if I'm listening to this and you're like, "Oh no," so I should reach out to somebody like yourself. So, is there a differentiation between a general physical therapist and somebody that specializes in pelvic floor? Like, is that a thing,
Yeah, it
differentiation wise?
It is a thing. It can be hard though, for the general public to like know how to see that or find that. So to become trained as a pelvic floor therapist, there are a few different institutes that one can go through. I went through the Herman and Wallace Pelvic Rehab Institute, and there are several others, and they're all, well respected, but you don't come out of it like with necessarily the same certification. So, like, if you're a gynecologist and you go do a fellowship in gynecology, no matter where you do it, you're going to come out as a fellow of the American College of Gynecology. We do have fellowships and we do have residencies in PT, but they're not required. And so some people might be board certified in women's health physical therapy. Some people might be certified pelvic rehab practitioners. Some people might not have any extra letters after their name and they're just as qualified. So you can't necessarily like pull up somebody's profile and, look at what letters are after their name and know whether or not they're qualified. I'd like to hope that nobody who is not specifically trained in it would be trying to practice pelvic health, but unfortunately unfortunately, that's not 100%. And so a lot of times it takes a little bit of digging into, looking at what coursework someone has taken. They should probably have it listed on their website or in their bio, and it should be fairly extensive. There should be more than one course in pelvic health to really know that someone has taken the steps to really become certified. So it's not an easy answer to your question. There isn't like, oh, here's this one thing you should look for. It's more about kind of reading between the lines and really getting a better understanding of someone's background.
Yeah. And I feel like a few years ago, I took a pre and postnatal certification. They were talking about just, pelvic floor specialists and all these different things, which I think are very common overseas. And it's something that I feel like is over the last few years is kind of starting to thankfully start to drip back into the US. And we're starting to see therapists and stuff because I think it's such a hugely overlooked space and women, need that type of support and education and knowing that it's not normal to be leaking every single time you sneeze.
Definitely. Definitely.
If we
And
can just
yeah,
change it that way, I'll be happy.
100%. Like that's like 90% of the battle is just knowing that it's not normal and you could do something about it if you so choose.
Yeah. So is there anything on the daily that I could be doing, any type of anything like tips or anything like that? Or is it such that it's just like, no, you need to go get help first so that you can start to get remedy for that. And then, it's something that you can continue with, down the path to help heal or whatever. What does that look like once one starts working with you to correct it?
Sure. So I think in an ideal world, everyone would get evaluated by a pelvic floor therapist at some point in their lives, whether or not they're having symptoms. But especially if you're having symptoms, that you would get evaluated, really understand the specifics of what you need to be working on, and get an individualized, tailored plan. However, especially on Cape Cod right now, there are fewer than 10 P- PTs and OTs on our entire county that have specialty training in this area. And so it's not totally realistic to expect that everybody will have that path. And so I think if find yourself in the group of people that either doesn't have access to it or just can't quite make that individualized approach happen in your schedule right now, there are general things that you can do to help improve your pelvic health. And one of those things is definitely to do core work and glute work in a way that is supportive to the pelvic floor. So, what I mean by that is when we do things like that really increase intra-abdominal pressure or like put a lot of pressure down on our abdomen and pelvis, like sit-ups or like heavy lifting, we can absolutely do those things. But if you do those things like exhaling so that you're decreasing the pressure down as you do them, you're going to automatically get a little bit of pelvic floor engagement and be a little bit less risk of doing anything that could be harmful. I think coordinating exercises with breathing is like a huge thing that people could be doing relatively independently once you kind of know what you're going for. I call it exhale on exertion. So, on the hard part of the exercise, you want to be exhaling to, again, reduce that pressure down. And then, as far as exercises that help the pelvic floor, they have done studies, again, with EMGs, putting sensors into the vagina to read muscle activity of the pelvic floor and so they measure it with a Kegel and they get a certain amount of muscle activity. And we consistently find that with exercises like bridges, squats, especially lunges, that you actually get more pelvic floor muscle activity than a Kegel alone. And you don't have to worry so much about whether the Kegel technique is perfect. That has a lot to do with just the anatomy, the way that the pelvic floor connects into the hip, as well as the amount of core stability that's required for those activities that kind of makes the pelvic floor come on. So there are a lot of exercises that you can do that really help your pelvic floor without having to be, certain that you're doing a proper Kegel.
Well, we do all that stuff at the gym every day.
Yeah,
So
awesome.
everybody will be so thrilled to know.
Yeah. No, that is great. And I think that's what's really cool about what you're doing, Jillian, is that you're doing stuff that's really good for everybody's body in so many ways, especially whether you or your clients know it or not, a lot of the things you're doing are so, so good for pelvic health.
Yeah, yeah. No, I have, like I said, done some general information just because I feel like it's so interesting, and I like to just dig around and always be learning on different things. And I think that we just don't realize like the depth of what our pelvic floor does, and just how important it is until something negative happens. Like we've had few members this past year that their insides are falling out and they have to get surgery and stuff, and it's scary. And I think in essence could potentially be preventable if we have the information and are able to find somebody that can help us.
Yeah, definitely. And to put a little plug in for pelvic PT in the context of prolapse surgeries. So sometimes even we can't necessarily change a prolapse dramatically in PT, but we usually can improve it a little bit depending on how significant it is. But what I really like to see people for with prolapse, even if it's quite severe, is preoperative and postoperative, because those surgeries have a pretty high failure rate, meaning within the first 10 years after having the surgery, a lot of people reprolapse. And that's because they have not retrained their pelvic floor, their core, and their movement systems to reduce the amount of pressure down on their pelvis. And so we see much higher rates of success with those with either or. So if you are someone who has had a prolapse surgery or have one coming up, you definitely do not think that pelvic floor PT is off the table for you. It's just like you would have surgery after a knee replacement or PT after a knee replacement, you should have PT after a pelvic surgery.
Yeah. And really, it's probably just more communication to our doctors and protecting ourselves and saying, I need to go see a specialist
Definitely.
because Christina is now in Chatham.
That's right.
She can help you. Well, I really appreciate you taking out the time out of your busy day to chat with us today. I look forward to having you back on the podcast so we can talk more about our bodies and joint pain and all sorts of fun stuff. But thank you again, and I hope that you have a great day.
Thank you so much. It's been a pleasure. Thanks so much for having me on.